see. We decided to mix things up a little bit, so moderator will be on the right side this time. Questions? We've got about 10 minutes. Questions, thoughts, reflections. There are microphones here and here. Yes. And please identify yourself.
Sure. Is this on?
Yes.
Yeah. Thanks very much for the insights. My name's Robbie. I'm a master's student here at Symbolic Systems. I used to work as a mental health social worker. This is a question about mental health theory, maybe. And although treatment is the ultimate goal, I think I'd be curious how maybe working in a more data-driven, prediction-driven mental health field has changed your understanding of mental health conditions themselves, or maybe the mechanisms that lead people to become depressed, for example. Or to put another way, what is the role of theory in a future of mental health care, which is more reliant on AI?
Really, Tom should answer that, actually. Has literally written a book about it. Tom, you want to start?
I'll finish.
All right. I'll start, actually. I think that maybe I would just start with a challenge. I don't know that treatment's the goal. I think that I'd love to have a world in which no one needed treatments for serious mental illness. Until we get there, though, I think we have to really recognize the overall toll it takes on individuals, their family, and society. And one solution, I believe, toward destigmatization, for example, is really the reconceptualization for how we describe these diseases. And we use things like schizophrenia still, obviously not to minimize its existence. It exists. We just heard about it. I don't know that this descriptor is particularly useful. And so some of the work that Tom had led 15 years ago or more was really around moving toward, a different way of conceptualizing the diagnosis. I think prior to AI, that was not really viable. And now maybe we can move toward a data-driven, biologically based understanding and description of the diseases.
That was great.
That was great. Thank you. I'll add to that a data-based, data-driven, science-driven conceptualization of diseases is essential. And a component of that science has to be the qualitative science that goes into understanding how people experience those conditions and how it affects their lives. So going beyond the symptoms, the actual phenomenology, and then how that translates into life potential. Like, is somebody able to go to school or go to work? I mean, if their negative symptoms prevent them from making good relationships in the workplace, are they going to be able to stay there? So often people wash out of workplace settings because their symptoms prevent them from interacting with others in a way that others can understand. So addressing things like that will be essential to improving the treatments to get to where they need to be.
Anna, anything to add?
Well, I think that we really have a unique opportunity to rethink, in a way, rewrite the way we are looking at mental health, because finally we can measure. We have no excuse, right? No more excuse. I think we have been a little bit of prisoner of our own story. And despite we have even a little bit earlier than today, the opportunity to be more data-driven, we followed a storytelling that brought us not close to data. And today, with this real focus on AI, I think that AI is going to be the enabler, or hopefully, I hope that AI is going to be the enabler to embrace a more data-driven approach and to bring really mental health at par with physical health. Because the storytelling, the words really had an impact on how mental health has been treated, has been considered. So I'm very hopeful. I think that data will help to clear the way.
It's such an interesting question historically, because for so many decades, this was all about theory and not about data. And now we're in a moment where that's flipping over. The only thing I'd add to what we've been talking about all day is that I think where AI is going to take us is not only with a better way of using brain data and biological data, but it will get us a lot more precision for behavior, emotion, activity, behavior, the things that actually we're supposed to be experts about in behavioral science. It's going to give us the kind of precision on those measures that we've really been lacking. So I think these were great answers, though. Thank you. Over here.
Yes. Hi, my name is Lynn. I work with NAMI as part of their peer support program. So your presentation on lived experience really resonated with me. And I definitely think it's important to have people with lived experience involved in research. The question I had is, outside of lived experience, there's also a very dark history of medical research, non-consensually experimenting on people, especially from minority groups. So how would you recommend getting people to engage with that history in mind?
Thank you. Thank you for calling that out. That's a very important thing to recognize. Yeah, that some awful things have happened in society with marginalized groups in science. I think that could be a part of the source of distrust that exists today. I'm sure that it is. So I think one way to start to do that is to incorporate peers in that process. So people who are currently involved in research and have lived with a mental health condition, or who may even be scientists themselves and living with a mental health condition, could serve as champions or ambassadors amongst communities of people with lived experience, including those in marginalized groups, especially if they're identified with that community themselves. I'd love to hear your ideas as well. Perhaps we could talk afterward. But it's a very important question. But that's one suggestion that I have for that. Any other ideas?
Yeah, I would just add that I think one of the values of NAMI has been to remind us that people with mental illness are also a marginalized group. And we don't usually think of it that way, but it may be an important reframing in an era where we care about equity, that they've really been left out of the conversation. Let's go on. We don't have a lot of time, so I want to make sure we get in some of these questions.
Hello, everyone. My name is Adriana, and I'm a high school senior. So I don't really have a question, but I really wanted to bring like an insight. So over the summer, I was an intern at the Autism Lab, and I was working with Dr. Hegarty. And one of the things that we really were talking about was, of course, we're developing these strategies and these treatments personalized, but we also tend to forget about acceptance and about how stigmatization is all because it's there because there are people who have this negative viewpoint on people on the spectrum. And so I just wanted to bring like an insight to that, and about how we should probably like open our eyes to being more accepting. And that's something that has been missing for a very long time. And I think Lynn, I don't know if that was her name, but she was talking about how research has had the power to both like empower ideas, but also bring the stigma towards groups, especially with autism. And so I just really wanted to bring like an awareness to that. And I wanted to thank our panelists today for being such open and giving all these beautiful insights. So thank you. Not really a question, but more of an insight. Thank you.
Thank you. May I respond to that? Thank you. Very important insight. Thank you for calling that out. Yeah, stigma is actually worse today for serious mental illnesses than it was 10 years ago. It's hard to believe, but it's true. And something that must be addressed to help more people seek the care they can benefit from, to re-engage in life again, to reconnect with their communities. A sense of belonging is essential to be a thriving human being. And at one line, we have a lived experience community, as I mentioned earlier, and we're looking for new members as well to add to that. If you're somebody with direct personal experience or a family member, we gave a great presentation at one of our organization's large convenings of business leaders. Our council did this, and the business leaders changed their perception of mental illness completely by hearing from us and seeing what we're capable of. That's one example of contact education, which has been shown to be very effective at reducing stigma. But we'd love to talk with you about that, who just spoke later. I would love to hear your insights.
This is why it's just so important to have you on so many of these panels. We need to clone you, and I guess you're trying to do that. Your voice is just absolutely critical for this conversation. We don't have much time. Let's take one more question, and then we're going to have to go on to the next session.
Thanks. Chris Buckle, formerly with Elevance Health, actually. Very interesting to get the panel's perspective on how we increase adoption in clinical trials and adoption of these new technologies. I understand a lot more from the physical health side, but mental health is unique. Why are we not seeing more engagement in those later stage clinical trials, and how do we get that greater adoption for these really innovative technologies?
Well, just looking around to see if Jonathan was still here. I don't know. I'm a PhD, not an MD, so that's my disclaimer. I don't know if there's enough humility in the current healthcare profession to accept new ways of thinking or doing. That's my opinion. I think you saw that reflected in some of the data where doctors with ChatGPT do worse than ChatGPT alone. I think that tells you something. I think the second part is something that Tom's talked about, is it's an incentive structure. So we have to recognize that people need to get paid. If you're going to change their workflow, they should be paid for the change in that workflow. So that does come back to a payer system. So those 3 A's that I talked about, approval, access, and adoption, they're all interrelated.
Other?
Yeah, I totally agree with what you just said. I mean, it's difficult to find a door open for a new way of thinking, and so I think that probably a tactical way to promote adoption of innovation is really making sure that it's not too disruptive. So, we talk a lot about disruptive innovation, and we talk about that with very positive connotation, but that makes everything even more difficult to adopt, right? So I think this field require gradual adoption and making sure that innovation is as much as integrated in processes that are already there, and is not too disruptive, because as you were saying, maybe there isn't enough humility to be very open to innovation.
That may be a good note to end on. Thank you very much to our panel and to our audience. Thank you.
Thank you for such an inspiring and powerful conclusion to today's presentations. Please join me in a final round of applause for this incredible panel. You've really given us vital, hopeful, and actionable vision for the future of precision mental health, and the importance of integrating people who have lived with these experiences. Now we bring our symposium's discussions to a close, and it's my absolute pleasure to introduce Dr. Rebecca